Hello, my name's Annabel Crabb, and I'm absolutely delighted that you could join us tonight for the latest Breast Cancer Trials Q&A. Breast Cancer Trials is the largest independent oncology research group in Australia and New Zealand, and they've been conducting clinical trials research into the treatment and prevention of breast cancer since 1978. And in the latest of these online sessions where we hook you up with experts to answer all of your questions, we're going to be exploring all things in relation to breast cancer and genetics. Now, the format of these is that we assemble a group of experts, and I, Annabel Crabb, totally inexperienced person who feels comfortable in asking stupid questions, directs my own and your questions to those experts. And I've got to say, tonight is a record crowd. We've got about 1,850 attendees on this virtual session, which shows that the question of genetics and breast cancer and heritability are hugely resonant among Australian and New Zealand society. You know, approximately 5 to 10% of breast cancer cases are thought to be hereditary, where a gene mutation has been passed on directly from a parent. About 1 in 400 women are at the highest risk of breast cancer because they carry their BRCA1 or BRCA1 or BRCA2 gene mutations. So I know with us tonight, we've got a lot of people who are either having been diagnosed with breast cancer or have someone in their family who's been diagnosed or cancer in their family history, really want to find out more. And that's what we're going to direct to our experts tonight. We're going to get to all of those questions, but I've got a tiny bit of housekeeping to do before we get there. Firstly, we're coming to this discussion from all sorts of postcodes and places today, and I want to make sure that we acknowledge the traditional custodians of the lands across Australia and New Zealand. I'm coming to you from Gadigal country in the Great Eora Nation, and I pay respects to the elders and the traditional owners of this land and from whichever land it is that you hail tonight. There's a great First Nations tradition of sharing information down the generations, and that's essentially what we're doing this evening. Okay, so I'm going to get straight to introducing our guest panel, who'll be answering your questions around breast cancer and genetics in this session. Okay, I'm going to start with Professor Geoffrey Lindeman. He's a clinician scientist focusing on breast stem cell biology, hereditary breast cancer, and translational breast cancer research. He's the joint head of the Cancer Biology and Stem Cells Division at the Walter and Eliza Hall Institute. Welcome, Geoffrey.
Thank you.
We also have Professor Kellyanne Phillips, who's an expert in breast cancer genetics, prevention research and patient care, and is a medical oncologist and senior strategic research leader at the Peter MacCallum Cancer Centre. Welcome, Kelly.
Thanks, Annabelle. Great to be here.
And we're also joined by Ms. Karen Alexander. She's a member of the Breast Cancer Trials Consumer Advisory Panel and was diagnosed with breast cancer in 2011. And Karen has a BRCA1 gene mutation. G'day, Karen.
Hi, Annabelle.
Thanks for joining us. And finally, Dr. Milita Zaheed, who's a staff specialist in cancer genetics at the Prince of Wales Hospital in Sydney. And Milita's the medical lead for ACT Cancer Genetics Service. Welcome, Milita.
Thank you. Great to be here.
Okay, so that's the panel. Now, I can't even tell you how many questions have been rocketing in from everybody who's signed up to be a part of this session. We've chosen questions that are broadly representative of the most popular questions and items of interest. But just to give you an idea of the spread of the inquiries around this particular topic, I just wanted to play you a little quick video showing you the sorts of things that people wanted to know. Okay, so you get an idea of the breadth of the inquiries that are out there. I guess, when anyone is diagnosed with cancer, there's more questions than there are answers, and it can feel overwhelming and confusing, and it's hard to know where to look or even where to direct your questions. And in this question of genetics and breast cancer, you've got people clustered around that person or looking at their personal family histories and confronting all sorts of scary possibilities. So that's why we've got this range of experts on hand to answer your questions today. So I'm going to start with you, Geoff. We're going to get into the research happening in the areas of genetics a bit later on. But before we do, let's start at the beginning. I already mentioned the BRCA and BRCA2 genes, but Cheryl has asked the question of how many genetic mutations do we actually know about that can increase your risk of breast cancer?
So that's difficult. How long is a piece of string question, Annabel? BRCA1 and 2, as you mentioned, I guess, are the most prominent and probably the most what we call prevalent that can predispose to breast cancer. And certainly, I'm sure we'll get a lot of attention tonight that needs to be discussed. And quite a number of genes, up to about 30 or so, have been identified that when they're inherited and are faulty, can increase the risk of breast cancer. But it's really probably about 10 to 12 genes that we focus on that are highly clinically relevant. And so there are different groups that offer, what are now called panel tests, that can look at these different genes. For example, in Parkville at the Peter Mac and Royal Melbourne here, we offer a panel of 8 genes routinely when we're thinking about looking for a predisposition. There are sometimes features in the family that make you look for some what are called syndromic genes. So really the answer...
Are those, Geoff?
Well, there are, for example, there's a syndrome called Cowden syndrome, which can give very rare mutations, P10, in a gene called P10. That's one example. Then there are genes that can give rise to certain types of stomach cancers that may send alarm bells and give rise to particular types of cancers. We don't routinely test for those, but the sorts of things a clinician might recognise and then test. The panel tests are really looking at things like BRCA1, BRCA2, gene called PALB2 or PALB2, CHEK2, ATM, RAD51, C and D. They go by lots of names. And another gene called TP53 or P53, which can be linked to a variety of cancers. So really, when one's thinking about this, you sort of focus on whether there are clues in the family history or in the tumour pathology for the patient who's been diagnosed that point you in the certain way of particular genes. But sometimes just a panel test can help address many of those.
So, and I appreciate, Geoff, that I'm delivering some of the least answerable questions to you in the first instance, so apologies. But what causes a genetic mutation? And Preeti has asked additionally if lifestyle factors like diet and exercise can have an influence.
So a mutation, our DNA is basically an alphabet of letters, and we're all different. So we all have slightly different alphabets that make up our DNA. But when there's a specific mistake that's made, that's a mutation that can be present in the DNA. And that's, of course, one copy of our genes is inherited from our mother and one from our father. And so we all have 2 copies of a normal gene. Sometimes we can inherit a faulty copy, and that's a mutation, or nowadays we tend to call it a pathogenic variant. So it's actually a mistake in the DNA that can't be changed. Sometimes when tumours arise that aren't inherited, changes can happen to the DNA. Either that area can be switched off or lost or mutated, but it's something that's inherited that is relevant for the discussions we're having today, and therefore it could be passed on, from parent to child. In terms of lifestyle, that's actually a really important question that's gaining much more interest and prominence. We know for breast cancer generally that exercise, having a low body mass index, and diet can contribute to cancer risk overall, and certainly for breast cancer. For example, we know, unfortunately, that alcohol can increase the risk of breast cancer, and even having more than 3 drinks a week can appreciably increase breast cancer risk. People are looking at these questions for women who have a genetic predisposition like BRCA1 or 2 carriers. And there is, I think, reasonable evidence when people have gone back and looked historically at studies to suggest that exercise can be very beneficial in terms of reducing breast cancer risk. Diet may also, like the Mediterranean diet, may also be helpful. And this is actually the subject of some studies that are testing this question prospectively to see whether or not influencing this can make a difference. For example, there's a study happening in Germany called the Libra study, which is looking at whether or not exercise and Mediterranean diet can actually improve outcome. One thing these things won't do is to change the spelling mistake that we're inherited. The truth is you can do all you like, but sometimes, bad things like cancer can happen. But it may be possible to influence those through some of the strategies that we're going to be talking about in this session.
Great. Thanks so much, Geoff. I'm going to turn now to Kelly. Look, the most common question, hands down, that's come through from our audience tonight is all about whether or not they should have genetic testing. And lots of them have given examples of breast cancer in their families. Is that a common question that you receive in the clinic? And specifically, Louise has asked, I think, a really good base question, which is, how do you define family history?
Yes. Well, I suspect that the reason there are a lot of questions about this is because, again, it's one that doesn't have a particularly straightforward answer. My own view is that, in the year 2022, really every woman with breast cancer should be asking her doctor if a genetic test for breast cancer predisposition genes would be relevant to her. So I think that's the first kind of simple thing that I would say. Please ask your doctor, your treating oncologist, if it's relevant to you. And, certainly every woman with a family history of breast or ovarian cancer, even if they don't have cancer themselves, should also be asking that question. I think one of the difficulties that we have in the current era, and I think this hopefully will change over time and hopefully relatively soon, is Medicare-funded genetic testing for these genes requires the woman being tested to have at least a 10% chance of having an abnormality in one of these genes. So that's kind of a high threshold, I think. So there are a lot of women out there with mutations in these genes who won't meet the threshold for criteria that put them at least 10% risk. So I think the other thing to say is that, if you think you want genetic testing and you're not offered a publicly funded test, talk to your doctor about whether it's worth you paying for a test yourself. These tests are somewhere between $400 and $500 generally now. So, some people would choose to pay for it themselves.
It's a bit cheaper than it used to be, isn't it?
Yes, they've come down considerably in price. So a couple of things have happened, I think. That 10% threshold's been there for a long time. And in the meantime, the cost of the test has come down. And the clinic, what we call the clinical utility of the test. So the things that we can do if we find out there is a mutation have increased. So for me, I think it's time that we started looking at bringing that threshold down. And maybe we'll talk about that a bit more towards the end.
So, Kelly, what are you talking about with family history? I mean, are you talking about someone with a grandmother or an aunt, or how narrow would you suggest the lineage should be to make you consider talking to your doctor about getting testing?
Yes, well, I think I think about this a little bit differently. So for people who haven't had cancer, then I think, if you've got 2 first or second degree relatives on the same side of the family, so on your mother's side or on your father's side, with breast or ovarian cancer, then definitely you should be talking to your GP about whether it's appropriate for you to be referred for genetic testing. For women who have cancer, even in the absence of a family history, so even if no one else in their family has breast or ovarian cancer, we know that they will cross that 10% chance of having a mutation threshold if they developed breast cancer under the age of 40, so developing it at a relatively young age. Or actually, there's a particular type of breast cancer called triple negative breast cancer, where it's much more likely to be genetic. And so for women diagnosed under 50 with a triple negative breast cancer should be considered for testing. Certainly men diagnosed with breast cancer should be considered for testing. And I think the other group is women with breast cancer in the context of having Ashkenazi Jewish heritage, because we know that these gene mutations are more common in women with Ashkenazi Jewish heritage, so we have a lower threshold to do the testing.
Thanks, Kelly. Those of you who noticed me giving a thumbs up to the screen just a minute ago, forgetting that I was currently on screen, it wasn't a sort of Donald Trump secret signal. It was me acknowledging to Geoff that he's got something to contribute here. So jump in, Geoff.
Thanks. And I agree with everything Kelly said. And I guess I was just going to add that we're in Parkville here, we're, I guess, challenging this 10% dogma that Kelly has mentioned. In fact, in the US, they're now issuing guidelines which say offer testing if there's a more than 5% probability. We've basically come to the view that why not offer testing to anyone who has just been recently diagnosed with breast cancer, and we're testing that model through the multidisciplinary team clinic here. Anecdotally, we're getting close to the 10% mark anyway, and it certainly, as Kelly said, has the potential to impact on patients' therapy, something we'll talk about, that Kelly will talk about a bit later, I'm sure.
Well, so how early should people be tested? And Francis in particular has asked, should children be tested if there's a family history? Kelly?
We don't generally test children because there's not really any clinical implications for children. There's nothing that we would change based on whether or not they had one of these gene abnormalities. So we really only test adults for these particular gene abnormalities. And how early someone should have testing is, that's a tricky question too. There's no blanket answer. It's really about when it's right for the individual woman. And, certainly I see patients who, know that there's a mutation in the family and want to have their testing pretty much as soon as they turn 18 because they just really want to know whether they carry that family mutation or not. And other women who, it's not uncommon for women to say, look, I just want to get all my childbearing and all of that out of the way before I go and do this genetic testing. But I think what's really important is when women are thinking about when to have genetic testing is, that they receive very thorough and full counselling, genetic counselling through the family cancer clinics around the country that can really help them to work out when it's the right time for them as individuals. That's super important.
Great. And look, just quickly, Kelly, I have always kind of broadly assumed, and now I realise I don't know why I assumed that these genetic mutations in breast cancer and ovarian cancer would be passed down through female ancestors. But Sarah's asked, can genetic mutations be passed down from both the mother's and the father's side?
Yes, indeed. So, these are genes that we all have, and they normally function to help protect us from getting cancer. And when one of these genes is faulty, we're more likely to get cancer. We have 2 of each one of these genes. So we have 2 copies of BRCA1 and we have 2 copies of BRCA2. And for each of those, we've received one of those copies from our mother's side of the family and one from our father. So absolutely, these genes, faulty genes, can be passed from fathers as well as mothers.
Okay, that's great to know. Thank you. Look, just a quick note, if you're wanting to ask a question, the way to do it is if you hover your mouse over the three little dots that are in the bottom right hand of your screen, that's the place to ask a question. So bring them in, and as I said, if we don't get to them this evening, we can certainly, if you leave your email address, make sure that that someone comes back to you. Look, I just thought now it might be a good opportunity to bring Karen into the discussion. Karen, thank you very much for being one of our heroic panellists who comes in to talk about their own experience of breast cancer. Can you tell us how and when you were first diagnosed?
Yeah, of course. So I got my diagnosis pretty much just on 11 years ago. So it was at the end of October in 2011. We were on holiday. We were in France and I was having a lovely trip. And one morning I was just putting on some moisturiser and I felt a small lump, but it was in a really odd position. It was actually quite high on my breast, almost more of my chest. And I thought that's a really strange spot for a lump because it almost felt as though, you know, when you've got a cold and your glands are up a little bit. And I thought, well, there's no glands there, so that's a bit strange. So I thought I'd keep an eye on it. A week later, it was still there and hadn't changed. So I actually called and made an appointment with my GP whilst I was still on holidays. I landed in Canberra at 11 o'clock. At 12 o'clock, I was at the GP and I said, look, can I have a referral for an ultrasound, please? She said to me that given my age and that I'd had a mammogram the previous year, being only 41, she said, it's probably just a fibroid. I really wouldn't worry about it. And I said, oh, no, I really would like to follow it up. So I was given the referral for the ultrasound, and then it came out that it turned out to be, yes, indeed, it was cancer. And then, you know, the biopsies, the core biopsies, and we did a lumpectomy. Just a lump was removed and it was tested, but it was quite an aggressive cancer and it already spread to my lymph nodes, even though it had sort of been very quick. And then off we went on the full journey of surgery, chemotherapy and radiation.
So at what point did you find out that you had the BRCA1 gene mutation, and were you the first person in your family to know that it was there?
So I found that I had the BRCA1 mutation quite late. So I'd completed all my treatment. My oncologist said to me, given my age and the type of cancer, because it was a triple negative, and being 41, she said, given those statistics, even though there was no direct family history, so aunts, uncles, parents, grandparents of having any cancer in my family, she said, I'd like you to have the genetic testing. So we did the genetic testing, and then that came out saying that it was a carrier for the BRCA1. But in amongst all of that, my mother had reached out to another part of the family. My grandfather had actually been married twice, and in the first half of the family, there were some pockets of cancer, and it turns out that they had the BRCA gene, but figured it had come through their mother's side of the family, so didn't really tell anybody else. So,
wow. Okay. Well, look, I have to say that Karen has been even more generous than our standard participants who are talking from a personal history of breast cancer. She has very kindly, and thank you, Karen, given us some artwork of her family tree so that we can actually see what we're talking about. So I might ask if we can share that image now so you can have a look at just how significant this pattern is within Karen's family. And again, thank you very much, Karen, for sharing. I bet you never thought you'd be flashing your family to nearly 2,000 people. But so we can see there that your grandfather is at the top, and he was married twice to two different women. And then there were cases of cancer on both sides of the family passed down to generations from the first and second marriages. So you weren't aware of the extent of that cancer pattern within your family until you investigated it, right?
Yeah, that's right. I mean, I was the first person in our part of the family to have cancer. So I kind of almost saw myself as the canary in the coal mine. It was like, okay, I had a very good outcome, which I've been very grateful for. And so we were then in a position that everybody else could have the knowledge that we gained from, my diagnosis. One of the interesting things that you were talking about before about you have an assumption, you don't know where you get these assumptions from. I don't have any siblings. So very early on, I thought, oh, well, if I've got the BRCA gene, it doesn't matter. I'm like a genetic dead end. I was thinking that it was a combination of genes from my parents, and that's where it had come from, not that it followed an individual line.
So I see from the family tree, Karen, that your mother had her ovaries removed and your aunt, who had stage 1 ovarian, had ovaries removed and preventative mastectomy, and a second aunt as well. And you've had cousins that have taken some precautions. Did that all happen, including the generation above yours, of your mother and your aunts, after you discovered all of this information?
Yes, yeah, that's right. So, yeah, up until that point, we'd had no cancer at all in our family. And then I had the finding that I had the BRCA gene. So then everybody else went and had the subsequent testing. And as you can see, my aunt, so she had the preventative removal of her ovaries. And that was when they discovered that she had the stage 1 ovarian cancer without symptoms.
Wow, because I think my assumption always is that this stuff happens it cascades down the generations, but obviously in your case, your discoveries meant that your older relatives could also take precautions. I also noticed from your family tree there, I'm really digging around in it now, Karen, that you have a male cousin too. What's his experience been?
So he had the genetic testing. He found that he had the gene, and it's really, for him, it's more about information. I think what has happened subsequent to us all finding out that we carry the gene, there's been a lot of conversations in the family about what it actually means. So what action do we need to take? Do we need to take anything? Do they really need to do anything? And for some of my cousins, it's more about having the information and just monitoring themselves and knowing if something feels different to do something about it. And there's other members of the family who are not interested in having the testing and are just not bothered.
I wonder if I could just bring you in here for a second, Geoff, and ask how often you see these patterns where you make a discovery, down the family tree and then trace it back up and alert people higher up in the branches. Is that correct? Don't know. You know what I mean? They're in an older generation and you're giving them news about that variation.
So that can happen not infrequently. In fact, it's, as you said, it's sometimes a surprise for people to discover that there's a gene there. Some of these genes probably date back, 2,000 years. We talked about the Ashkenazi genes. They probably arose in Russia and then through Jewish communities in Middle Europe, 400-500 years ago. And sometimes you just see something in a family and then that triggers what's called cascade testing to other family members. And then the penny drops, as we've just heard. And that event, I like the description canary in the coal mine, because you also then have to be the family genetic housekeeper, and which can be quite onerous, in fact, because then information has to be passed on to family members, and the familial cancer centres are very good at helping people to do that, because it's not always easy letting other people know in the family that there might be a gene fault that, as we've heard, can be very well addressed through, in this case, preventive surgery or rigorous monitoring.
Can I ask you, thanks, Geoff. Karen, can I ask you just, because I imagine there would be lots of people in this session who are confronting this possibility in their own families. How did you approach talking to your cousins, for instance, and how are they responding to the news? Particularly, I can see that a couple of your cousins have, one of them has a 16-year-old daughter and also a 4-year-old daughter, and your male cousin has a newborn daughter. How are they approaching this news and managing the situations in their own families?
At the time, we, so, you know, in a good family hierarchy, I spoke to my grandmother and explained to her that, you know, this is what was happening and this is, you know, what we'd all be doing and that we'd be talking to everybody. Mum did the initial reach out to her siblings because at that time I was still recovering from all my treatments. So I wasn't really up to having
managing the entire family,
everybody there. So Mum did the initial conversations and then I did all the follow-up, particularly with my cousins. I guess it's just easier for me to relate to them. But there were also more practical considerations for my younger cousins as well, because I'm the eldest of all the grandchildren. But even simple things like, do you have life insurance? You know, do you have that in place before you start doing tests to identify whether you've got a genetic mutation? You know, maybe if that's something you need to get, you need to sort it out before you say, oh yes, by the way, I do carry a BRCA gene. But really, just talking to them about what my experiences were, and that the genetic counselling process was really very simple. I think at the time I did this, you know, Kelly, you were talking about the cost before. I think they were running at around $3,000 for people who didn't meet those criteria then. But clearly for my cousins, they sort of met that threshold. So just talking to them about, you know, it's a very simple test and it wasn't intrusive or unpleasant. It's a simple blood test and a good conversation with a genetic counsellor. And by already having that information, it sort of helped direct the counselling process. That was a little bit quicker.
Great. Thank you again, Karen, for sharing that extent of your family information. We really do appreciate it. And it's really powerful to have that visual demonstration of how these patterns can work. I want to bring Milita in now to these sort of brass tacks questions of what genetic testing is all about and how it works, because a really common question that we have received is, how do you get the genetic testing? Can anyone get it? Where do you go? Where do you get the advice from about how necessary it is in your case? We've talked a little bit about costs, but if you can give us a little bit of a refresher on those issues, please. We'd love a sort of step-by-step guide, I guess, to how to proceed.
Thanks, Annabel. I guess there are effectively two different types of tests. So there's the tests, the kind of test that Karen would have had, which is where, you know, she's the first person to have genetic testing in the family, where a gene fault is not known about. And so in testing like that, we test for a panel, as Jeff was saying. So generally we try and put as many genes in that panel as would be sort of relevant to that sort of the clinical picture. And we are searching for a gene fault. And then there's the other part, which is where what Karen's family, the relatives would have had, which is the sort of looking for that specific gene fault. So we are not doing a genetic search, we are looking for that specific change. And actually just coming back to what Karen was saying, I think, you know, it's absolutely wonderful, Karen, that you and your family shared that information. In the familial cancer clinics, we feel very passionate about people relaying that information, but, you know, as sort of clinics and services, we don't have, you know, it's their information and we don't have control over what is shared. And as you can see, there's that opportunity for prevention, for, you know, understanding risk and taking all those things on board, which Karen would have done. She would have been having breast MRIs or screening if Karen had known about it. So sharing that information really allows for, you know, the extended family to benefit from this, from that sort of experience. So going back to sort of the ways to have testing, ideally the person will be tested through a familial cancer clinic, so either in the public system or there are private clinics as well in some locations. So anywhere in Australia is covered or serviced by a public service, and that may be sort of, kilometers away, but, there are public services that cover for that. So the first step, as Kelly was saying as well, that if you're thinking about genetic testing, really the first step is to have a conversation with somebody. So if you have an oncologist, if you've been affected by cancer, then the best person to probably have that conversation with are your cancer specialists. And I guess following up on what Kelly was saying, that it's a moving feast in terms of the threshold for testing. So while we are still set on that 10% threshold, we are gradually moving away and broadening the sort of people that we test. So if someone has had a cancer diagnosis, say, a decade ago, they may not have been eligible, or we may not have thought about genetic testing, but it is worthwhile raising that, having that conversation with their specialist. For people who haven't been diagnosed with cancer, but have a family history, or they're just wondering whether it is something for them, then I would say to have that conversation with their GP specialist about whether in the context of their family history or their whatever, whether that's something worthwhile. In general, they will get referred on to a public service, a familial cancer service, or a private service, and then they will get seen by a genetic counsellor or a medical specialist who will assess their personal history as well as their family history and put that into context. So, some families there have a lot of males and not a lot of females. So you need that expertise to be able to assess that actually Karen is an only child, or she's the only female, and her dad only had brothers, or things like that. So you need to be able to put those things into context. Then we look at sort of eligibility, and as Kelly was saying, Medicare has this threshold of 10%, and in the sort of the state-funded system, we also have additional criteria where we will fund, genetic testing, publicly fund genetic testing.
Right.
Outside of that, there is the option of having privately funded genetic testing, and the costing for that has reduced so much from sort of thousands of dollars to sort of somewhere between, as Kelly was saying, $300 to sort of $500.
And good people should be able to point you to pursuing that option.
Yes, or the genetic services that you're seeing. Right. There are also now virtual platforms that will do that sort of consultation and genetic testing for you, which sort of improves the access. So there are some that are based in Australia. Okay. The thing to say is that there are direct-to-consumer testing where a person can log in and just request testing. They are really tricky, and often they are not that is not their area of expertise. They're not validated. They're not accredited. So we sometimes get results back and we, don't know what that means. So it's really important to use a lab that has been accredited by sort of, set standards to report on these kind of results. So it does need to be requested by a clinician in sort of most circumstances.
Oh, thanks, Milita. That's a really valuable clarification, because, of course, people jump onto Dr. Google straight away and work out what their options are. So it's great to have that clarification from you. I've got a couple of quick-fire questions for you just that have come in about individual circumstances. Sharon says that she has had breast cancer throughout her family, but they've tested negative to known gene mutations. Is it possible that there are mutations we don't know about yet?
Yes, there is. So, I guess the BRCA1 and 2 genes, the faults in those genes, they were discovered in the 1990s. And so, over time, we're discovering more and more genes. And currently in the clinical space, outside of research, we are really able to test for genes, a single gene which has an effect, a sort of significant enough effect in increasing someone's risk of developing breast cancer. But what we are also realizing is that, it's more complicated than that, sometimes it is not just a single gene fault, it's a combination of gene faults. Sometimes it can be hundreds of sort of slight changes in the genetic information, as well as sort of genes interacting with other genes. So
Sharon's best advice is to really continue with breast screen and all of the, just paying very close attention to.
That's right. So as long as someone who has been affected by breast cancer has had testing or ovarian cancer, then we know that in this family, it's the family history is saying that there is an increased risk, but we just don't know what that cause is. So they still need to have those tailored risk management based on the family history.
Okay. Look, quickly as well, we had a question from Joanne, who said that she was tested for genetic mutations several years ago and it came up negative, and she's wondering whether she should get tested again now with everything that we now know today.
That's a tricky one. So yes, we are in general going back and retesting some people. It sort of needs a review by the team that looked after her. In the past few years ago, we were using older technology for sequencing, and we had to do one gene at a time, and it took a really long time. So we were only testing BRCA1 and 2. Whereas now we're doing panels and we're using newer technologies. So it depends on how long ago it was. And the simplest thing would be to contact the genetics service to say, hey, do I need an updated test?
Okay, great. Thank you. And Joanne, I hope that answers your question. I'm popping back to Geoff now, and I just wanted to report that there's a really common question coming through live from people online, which is, do you have a higher risk of recurrence if you have a confirmed mutation? Geoff, is that something you'd tackle for us?
No, there are, I guess, two ways of looking at that. The first is the risk of recurrence of the cancer that a person has just had. And we do, I guess, feel that BRCA1 and 2 associated tumours may be more clinically aggressive. However, we know that if they're properly treated, that risk may then abate back to the sort of average breast cancer risk. So it's helpful to know that, of course, that there's a faulty gene there in the first place, because it could influence how one gets treated. The second part of that question is that what about a second new cancer? And we do know that BRCA1 and 2 carriers have a higher risk of developing a second breast cancer, and that's sometimes why they think about having a preventive mastectomy at the time that their, I guess, first breast cancer is diagnosed. So yes, if you treat it properly, and as we'll hear, I think from Kelly, there are new drugs on the horizon that will make these tumours even more treatable, that the risk can then be brought back to sort of an even playing field. But yes, then there's the question of second cancers.
Thank you. I'll ask a question now from Sarah to you, Geoff. Is there testing for different mutations aside from BRCA1 and 2? And are there also blood tests that can be done to determine if you have a high risk of developing breast cancer?
Yep. So I guess the first part of that is really something that Milita just talked about, and that is that we now are more focused on panel testing, where we're assembling a panel of genes that we think will be most relevant to check for that person. And sometimes it might mean actually going back if the old technology was used. The second part of that question really relates to something I said at the beginning, and that is that we're all different and we all have different sequences in our DNA. And there are these things called SNPs, or single nucleotide polymorphisms for long. But more than 180 of these SNPs have been identified already that could collectively increase the risk of developing breast cancer. And people are beginning to explore testing for these SNPs, which may account for about 20% of familial breast cancer, whether they can be applied clinically. There are, the private sector is always very good at jumping on these sorts of bandwagons. And so with all those caveats, I think, coming here soon is the prospects that people may be able to undergo SNP testing to see whether there is some influence on breast cancer risk, but it's not really quite ready for prime time would be my take. It's probably best conducted in a research setting.
All right, good to know what's in the what's coming down the pipe. Geoff, a whole bunch of people have asked if you can still have genetic testing if people in your family have already died and they can't be tested, but you know that there's a history of cancer there.
Yeah, so that's potentially possible. Normally, in fact, by law, a piece of the tumour sample that's been looked at by the pathologist has to be stored in a pathology archive. And sometimes it's possible to go back to that tumour block and to do sequencing of that tumour. It depends on the age of the tumour, where it was stored, how it was stored. So the feasibility is something that's often a question, and it's not really readily available, but yes, the potential is there, and I suspect we're going to get smarter over time. Just going back to that SNP testing, there are lots of other things that are being applied. People are looking at breast density. There are whole lots of measures that are, in addition to the genetics, that are being looked at.
Okay, and we also had a question in from Paul, who's asked whether inherited breast cancers are always the same type of cancer within the same family.
So different gene faults can predispose to certain types of cancer. We've already heard from Karen about triple negative breast cancer, and that's more linked to BRCA1 tumours. So there may be a more predisposition for developing those types of tumours. Ovarian cancer can be more common for BRCA1, also seen for BRCA2. So yes, sometimes the pattern of the tumours can influence it. I mentioned right at the beginning cancers of the stomach. Sometimes there's a very rare gene mutation in a gene called E-cadherin, which can give rise to lobular types of breast cancer. So that there are patterns of tumours that we look for, but there's not great fidelity within families, so you wouldn't necessarily expect everybody with a BRCA1 mutation to, if they're going to get breast cancer, to get a triple negative breast cancer, for example. So there's a little bit of circumspect thought has to be given to this.
Kelly, did you want to jump in here?
Yeah, thanks, Annabel. I just wanted to get back to that question about, well, how do I know what my own breast cancer risk is? And Geoff's been talking about kind of the genetic factors that impact on breast cancer risk, but there's a whole lot of factors that impact on an individual woman's breast cancer risk. And, it's actually really important to know what your own risk is, because once you know that, you can then get advice about how best to manage it. So, actually, breast cancer trials helped to seed fund some research that led to the development of a free online tool that women can use to assess their own breast cancer risk and work out how to manage it and whether they need to go to a family cancer centre. So if you just Google iPrevent, that's what it's called, iPrevent.
Lowercase I, capital P, iPrevent.
Exactly, kind of like an iPhone, but iPrevent. Then you should find it. It's on the Peter McCallum Cancer Centre website, but it's also hosted by Cancer Australia and various other peak organisations. Yeah.
Can I just jump in with a really super stupid question, Kelly? If you have a family history of different types of cancer, I don't know, lung, bowel, what is that? Can that contribute to an enhanced risk of breast cancer?
Yes, so this kind of comes back to these different syndromes that we were sort of alluding to earlier. It's a bit complex to try and describe all of these syndromes in a forum like this. But I think, certainly the things that tend to hang together with breast and ovarian cancer is also prostate cancer and pancreas cancer. If you're seeing those clusters, that's really important. But if you're seeing a lot of cancer in your family, go and talk to somebody about it, because there are other less common syndromes that can be associated with other types of cancers in the family.
And I guess the things you're looking for are higher burden of cancers than you would sort of, expecting, your friends and other people don't share the similar burden of cancers, and younger age of diagnosis. So, lots of cancers in their 80s is probably not that exciting. As you get older, our body makes more mistakes. But if you have family history of multiple relatives with young onset cancers, regardless of the type of cancers, it's worthwhile having that conversation with somebody.
Great, thank you for that response. I've got a couple of questions to gallop through with you, Kellyanne. We want to try and make sure we get to everything, and of course, as is customary at these events, the time is ticking away. Kelly, it can be a pretty scary experience, of course, to be diagnosed with a genetic mutation, particularly if you don't already have cancer. What are the most common concerns that you hear from patients when they learn that they have this genetic mutation?
Well, when it's a patient who's been newly diagnosed with breast cancer and then finds that she has a mutation at the same time, this question about, is my outcome going to be worse because of this? That's a really common question. I think we've kind of addressed that. Another common question is, what does it tell us about my future cancer risk? So worry about what's the next cancer that's coming and can we do anything about it? And, I think commonly we also see worry about what it might mean for children. I always like to remember, though, that I've been in this game for a long time, actually. I started research in this area in the mid-1990s when these genes were first discovered. And, in that time, just so much has changed, and we are so much better at looking after these women with breast cancer and also in preventing breast cancer. But, I like to explain that for young children who may or may not have a gene mutation, things are going to be very different in 20 or 30 years old when they're getting closer to developing cancer. So I think that's really important for people to remember. Yeah.
Okay. And Sue asked whether treating patients who have a BRCA1 or 2 genetic mutation is different from treating patients who don't. I think I'm sort of extrapolating from earlier remarks that there isn't necessarily a huge difference in the actual clinical treatment of those cases.
Well, women who have metastatic breast cancer, we do, in my view, we should be routinely testing all of those women to see if they have a mutation, because there are different treatment options that are open to those women. Already in other countries, there's a new treatment option really that came out of research from BCT that's already available for women with potentially curable breast cancer. And, I hope that that's not too far away for Australian women as well. So there will be differences based on whether or not women carry these mutations or not.
What are the options, Belinda would like to know, what are the options available for people with genetic mutations to prevent breast cancer?
Yes. So, the most effective thing that we can do to prevent breast cancer, the thing that reduces risk the most, is to remove breast tissue. So we know that if we remove both breasts, which is a procedure that's usually done in conjunction with a reconstruction of the breast tissue, we know that that reduces risk dramatically. And, after women have that procedure, even if they have a gene mutation, their risk of developing breast cancer is then much lower than for other women in the general population. So it's very effective, but it's not for everybody, as you can imagine. It's a very personal choice. We also have medications that can be used to prevent breast cancer. So there are anti-hormone medications that are useful in women in general who are at increased risk. There's a lot less data about those in women with these gene mutations, but likely they're probably quite effective in women with BRCA2 mutations. I think there's a question mark about BRCA1 mutations, and I hope Geoff will have the opportunity later to tell you about a really exciting study that he's running that's going to look at preventative options in women with BRCA1 mutations. And then, of course, we've mentioned lifestyle factors, but they are really important because, the lifestyle factors are probably more important in women with mutations than they are in the general population. So we shouldn't forget that. When I first started in this game, we used to think, it doesn't really matter. None of those things matter because it's all drowned out by the gene mutation. But actually, that's not true. And lifestyle factors are important as well. And then, of course, not in terms of preventing breast cancer, but we do try to detect breast cancers early if they do occur by undertaking screening, which is usually intensified for these women with mutations. So not just a mammogram every 2 years after age 50, as it is for the general population, but for these women, we're really talking about starting screening much earlier and using MRIs to get a much clearer look at the breast tissue as well.
Thanks, Kelly. I'm just going to divert via Karen for a minute because I know, Karen, that you discovered you had the gene mutation when you were already well through your treatment for breast cancer post-diagnosis. But I wanted to know what that knowledge of knowing you had the mutation meant for you in terms of the next steps in your treatment and recovery plans.
Annabel. So I guess, as you said, so I'd completed all my treatment. I was all done, and being a triple negative, treatments were finished, and I wasn't taking any follow-on medication. So to get the news that I carried the gene was a bit frustrating, a bit distressing, because that meant a whole new round of things to be undertaken. So my first step was to go back and talk to my oncologist about what that actually meant. And her advice at the time was, and bearing in mind that this is a long time ago now, it's 11 years. So she said, look, her advice would be, have your ovaries removed as a priority, because it's so difficult to test for ovarian cancer. So that was her recommendation. And she said, and having your breasts, having a bilateral mastectomy, she said, it's not such a critical thing for you to do because, there are so many screening options available to you. So I then went and met with, reconstructive surgeons, spoke to pretty much all my treatment team and took a poll to see what everybody said. And then ultimately I made the decision that I wanted my life. I didn't really want to think about it anymore. I wanted to do everything that I could to try and alleviate or eliminate the risk as much as possible. So I did have my ovaries removed as a first step, and then went with the bilateral mastectomy and the reconstruction.
Wow, they're big decisions to make for a woman of your age.
Yeah, at the time it was, I guess I didn't have children, and I was really not sure whether I was going to have children or whether I wasn't. But taking that definitive step to do something to really remove that choice was, I guess, in some ways an emotional decision, but I'm quite a pragmatic person. And I thought, look, realistically, I need to do what I can to eliminate the risk as much as possible.
Thank you, Karen. I'm going to go back to Milita now and just get you to talk about the comparative risk between mutations. We know that there are different ones. We're all broadly familiar with BRCA1 and BRCA2. They are the most common, as I understand it. Do they create a greater risk of developing breast cancer compared to other genetic mutations, or are they all kind of created equal?
Yeah, very, very good question. So I guess BRCA1 and 2 are the ones that we think about most, and the ones that I guess we have known about the longest. They're actually not the most common gene faults associated with breast cancer risk, but I guess has the most utility, the most sort of, the more that can be done, I guess, in the treatment space and otherwise as well. BRCA1 and 2, they're high breast cancer risk genes, and so with the breast cancer risk, the likelihood of developing breast cancer to the age of about 80 is about 70%. So 70 out of 100 people who carry a gene fault in BRCA1 or 2 will go on to develop breast cancer. It's not 100%, but the risk is really quite high. Whereas there are other genes like CHEK2 and ATM. There's a specific change in ATM, sort of trying not to get into the details, but there's a specific change in ATM, which is a higher risk gene. But otherwise, there are changes in ATM and CHEK2, which are actually quite common, especially in the people of European ancestry. And the ATM, if you have 2 copies of the 2 faulty copies, then it's associated with quite a different kind of clinical syndrome. But there are a lot of people who carry a fault in these genes, and the cancer risk associated with that is a little bit higher than the general population. It is, meaningful, but it's nowhere near the BRCA1 and 2. So not all gene faults are created equal. And I guess the reason we identified BRCA1 and 2 earlier on is because of the higher burden of cancers, whereas you can, and we frequently see people who have had genetic testing for other reasons who have incidentally been found to carry a gene fault in one of those lower risk genes. But knowing about it is still useful.
Thank you. I'm reminded again that there are no easy, straight answers in this field, are there? But I think a lot of people on this call may find themselves at the very beginning of what we call the cancer journey, where everything seems scary and confusing. So I want to thank all of you for just contributing your little searchlights of light and providing information to people who are desperately in need of it. I want to come and talk about trials, because breast cancer trials has obviously undertaken a number of clinical trials in an attempt to improve treatments for people with genetic mutations. And there's a trial that's currently open called BRCA-P, which is a world first study, and it aims to prevent breast cancer in women who carry the BRCA1 gene mutation. I've got a little video to show you. It concerns Samantha. She's a participant in the BRCA-P clinical trial. She was 22 when she found out that she had the gene mutation. Let's have a quick listen to her story, and then we'll come back for some questions.
I think I was roughly 21 or 22 when I found out that I was BRCA1. My mum had breast cancer, and my auntie also had breast cancer. She unfortunately passed away from it. That's when we found out that it was the genetic mutation, BRCA1. It's a scary concept of being told that you could develop breast cancer and you have a disposition for it. The BRCA-P clinical trial is all about preventing breast cancer. With the BRCA-P trial, you get a 6-month injection, but you also get physical exams and blood testing and everything. So even if you're on the placebo, you're still getting a positive out of the trial. So if the BRCA-P trial wasn't available, there is the option of preventative surgeries such as double mastectomy. At about 21, surgery was definitely off the cards. Now that I'm 27, it's there, but it's still something I'm not confident in doing. The BRCA-P trial really takes away some of that anxiousness. Knowing that I have 6-monthly reviews, I could be on something that does prevent breast cancer. I do feel like that I have more control over my life knowing all of this information, knowing who I can go to, knowing who's there to support me, I'm not just sitting around waiting to develop something scary. I am taking action. I do feel proud to be on the trial, to support those generations coming after me. Having more options for people going through breast cancer is something wonderful.
Well, thank you to Samantha for sharing her story. And I'm going to go to you, Geoff, and ask you to just explain how this clinical trial came about and how it's being conducted.
Thanks, Annabel. It was great to see and hear Samantha's story. And it reminds me that it was a pandemic ago since I've been to the Heidi Gallery, which is a beautiful art gallery for anyone who hasn't been. The BRCA study is kind of about 20 years of work for me and Jane Visveda, who've worked on breast stem cells and really been interested in understanding how breast cancer happens through understanding normal breast development. And quite a few years ago now, we discovered the breast stem cells that give rise to the ductal cells in breast tissue and discovered the daughter cells to those stem cells called progenitor cells were somehow had gone awry for women with a faulty BRCA1 gene. So really, by discovering the cell type that gives rise to breast cancer, we started to explore whether there were ways we could switch off this gene switch off these cells before they even became cancerous. And one of the things we discovered was that there's a marker on these cells called RANK, R-A-N-K, which is really a target that can be gone after clinically. And we discovered that by switching off this, the RANK pathway in breast cells using both laboratory models but also breast tissue from BRCA1 carriers, that it looked like a way that we could either delay or prevent breast cancer development. And really those laboratory studies have led to with work of others overseas, of course, have led to an international prevention study that's being run by Breast Cancer Trials here. And what we're looking at is whether a drug called denosumab, which switches off the RANK pathway, it's a RANK ligand inhibitor, is its action. But basically, we're looking to see whether this drug can switch off these culprit cells and prevent cancers. And we feel confident enough that it's going to have a positive signal that the study's actually been fast-tracked to what's called a phase 3 study, where it's being compared, as Samantha said, with a placebo. So we can truly study not only the potential efficacy of this approach, but also the safety, because safety is always very important, particularly when you're thinking about a well woman who you don't want to make unwell. Denosumab's showing promise because we already know a lot about the drug. It's been used in the clinic to help for women with osteoporosis and men with osteoporosis to help keep their bones strong. And it's also used in the clinic for people whose breast cancer has spread to their bones. So we actually have a good understanding of the safety profile of denosumab. And so, yes, something that's very promising, and it's something, as we heard from Kelly, not everybody opts for mastectomy. It's a very personal decision. And also from Karen, sometimes you've got to choose the right time for that decision. And since about 70% of people don't have mastectomies, it's something they might consider doing, going on the study and getting very good clinical care from their own, specialists, but also the trials team. And in a sense, answering a question that might be of benefit to the next generation of women.
And this is very exciting, and thanks for outlining it to us. Is this research, does it have the potential to help other cancers as well?
Well, the principle at the moment looks very specific for BRCA1, but we know from preclinical models that switching off this pathway is actually very important for helping to prevent other hormone-mediated breast cancers. So the principle has potential for other cancers, but it's something would have to be explored rigorously in early phase studies to be sure.
Sure. And so who can participate in this study? I imagine that in this vast community that's listening into our session this evening, that you will have young women who are aware of a genetic mutation in their family. What are the first steps to participation?
So probably the easiest thing, to be honest, is to go to your favourite web browser and to look up breast solution or just through the Breast Cancer Trials website. So there's a portal there called Breast Solution, and that lists the criteria. And if people want to hear and know more about it, they can click on an expression of interest and actually answer specific questions. What we're really looking for this study are, of course, women who are BRCA1 mutation carriers or have a faulty BRCA1 gene, who are aged between 25 and 55 inclusively, and who haven't had breast cancer previously and haven't had a mastectomy, because what we're looking for is to see whether we can, as an endpoint, try to prevent cancers from happening. So women who aren't immediately thinking about mastectomy would be eligible. Women who are breastfeeding or thinking about having a child would not be suitable for this study in the short term, but actually we've been very flexible in the trial design, so women can actually go on study if they want to choose to then have a baby. They go off the study for a period and then can go back on it after childbirth. So yeah, probably the best thing is to click on that website, but also to ask their own specialists about it and their own GPs about it. But looking at the portal might actually be a good way of finding out more.
Great. Okay. Thanks, Jeff. And Kellyanne, you've also led some important research in Australia into improving treatments for patients. Can you tell us about your work on the Olympia clinical trial and what was the aim of that research?
Yes, so Olympia was a very exciting trial that's had groundbreaking results. So it was a big international study of over 1,800 people with breast cancer in the setting of a BRCA1 or BRCA2 mutation who had potentially curable breast cancer. And after they received all of the standard anti-cancer treatments, so surgery, perhaps chemotherapy, radiation, whatever, they were then given either a new drug called olaparib or a placebo. And they were given that in tablet format twice a day for 12 months. So it was a massive undertaking for these people who went on this study, because that's a big call to go on a study of something that's 12 months of medications after you've just been through all of that breast cancer treatment. But I am so grateful to every single participant in that study, because what we discovered is that if we do use olaparib for 12 months at the end of the breast cancer treatments in the setting of a BRCA1 or 2 mutation, we can improve survival by over 30%. This was actually a really surprising result. I mean, we thought this trial, if we were lucky, would be positive. I never dreamed it would be that positive. So this is really exciting. This is already being rolled out as a standard of care in many countries around the world. And I really hope that it won't be too long before we have it on the PBS in Australia. It's a very expensive drug, so if it's not on the PBS, it's quite difficult for people to fund. But groundbreaking research.
How expensive is the drug?
Yeah, well, a 12-month course costs about $80,000.
Wow. Okay. And so the drug, I assume, is in the current process of wending its way through the labyrinthine processes of PBS approval.
Yes, well, of course, there's always a cone of silence around these things. But yes, I'm sure it is being submitted for PBS approval. And, it's so important to those, this small subgroup of women with breast cancer who have these mutations. And I'm really hoping that we're going to be able to offer that much more cheaply to women soon.
Often people who have had a cancer diagnosis are always looking out for new trials or hearing about drugs that seem promising. Can you give us an idea of how long it took this Olympia trial to get underway and then yield significant results? I mean, what is the life of a successful trial like this one?
Yeah, well, this trial started in about 2014, I think, and the survival results have just come through
Pretty fast.
beginning of this year. It's an incredible trial, really. I mean, there were many people that said when this trial was started that it couldn't be done, that we couldn't get 1,800 women with these mutations, even if we did it globally, but we did. The reason we've got a result probably a little bit earlier than we had anticipated is because it's such an active drug. I mean, if it had been less active, we probably wouldn't have seen the benefit for a longer time too. But they take a long time. You're right. What you're alluding to is correct. These trials, particularly of potentially curable breast cancer, take a long time to do and a long time for the data to mature. So we've got to be really patient, and they take a lot of money because we've got to follow people for such a long time.
Breast cancer, I guess, is an area where research and treatment has progressed inordinately over the last 20 years, right? I mean, the outlook for somebody diagnosed with breast cancer today is very different from where it was a couple of decades ago.
Absolutely. I mean, in that, in the Olympia trial, the overall survival at the 4-year time point in the olaparib treated arm is 90%. So it's not bad, particularly considering a lot of these women would have very aggressive triple negative type breast cancers. So, yeah, we are really making incredible headway in breast cancer. But really, we can only do it by running these big clinical trials that take a lot of effort and a lot of funding.
It must be one of the best parts of your job, Kelly, to put the effort into this research and see it translate into improved outcomes for patients.
Absolutely. I mean, this is what it's all about. But I do want to make a very important point that, people like Jeff and I that, lead the clinical trials, we tend to get a lot of the credit when we get these groundbreaking results, but we really have to remember that, the participants are doing the bulk of the work, and there's a whole team behind people like me when we're doing trials like this. There's a whole team at breast cancer trials that work incredibly hard and should take just as much credit for these results as I do. And not to mention the people who donate to breast cancer trials, because that is such an important contribution. Without the money, these trials can't be done. So credit in all quarters.
Yeah, they're really great points. And I also think we could acknowledge people like Karen who stick around to talk about their experiences and use them to enrich the sort of information that we have about what it's like to go through these processes. So thank you to everybody who has donated, who has participated in trials, or who has stuck around to share their story, because it all is part of this huge multilateral process of tackling these cancers. Milita, you're currently doing a PhD in investigating opportunities to improve identification and care of individuals with cancer predisposition syndromes. Can you explain how your project came about and what you're hoping to learn from it?
I know we are short on time, so I'll be very brief, I guess. I guess the research comes from the clinical experience, and I guess what we've been talking about, that there are the demand for health dollars, there's just so many ways that health dollars can be spent. And I guess it's about being as efficacious and, having the greatest bang for your buck. And, we are limited by guidelines at the moment in terms of family history and things like that to test people. But we know that we are missing people, that there are people out there in the community who carry a predisposition that we are not able to offer testing to or are not being recognized. And I guess my PhD has come from that need and looking at different ways where we can enrich the people who we test and will end up with a positive result, sort of a gene fault, without sort of a balance between testing everybody, which really, it would be fantastic to do, but, it's not something that's really feasible with the sort of the expenses and the resources that we have available. So my PhD is looking at beyond breast cancer because, breast cancer is very important research in this space, but also there are other cancers and cancer predisposition, which also require, just as, I guess, useful to know about. And so my research is looking at different ways how we can recognize these people, such as looking at people who've been diagnosed with cancers at a young age or rare cancers, which, obviously because it's rare, doesn't get as much traction, and looking at sort of different avenues like tumor testing, which is happening more often now, and sort of using that information to identify people who might carry a gene fault.
Thanks, Milita. Well, in the 10 minutes that remains to us, and yes, the time has flown as predicted, I'm going to open up to the whole panel and ask a question about research. Is it difficult to work out what research question to ask, whether it's in the lab or in the clinic, when we still don't know everything about human genetics? Jump in, anyone who wants to tackle that one.
No, the number of questions I have, I think because they're, genetics, cancer genetics is a relatively new field, in the sort of scheme of things. And there's just so much to know. And the more we know, the more questions we have. It's just a matter of having enough resources to be able to answer those questions. I don't know about you, Kelly and Jeff, but I'm always, every week I have a question. This is my next thing on the list after my PhD.
And does it start sort of with a hunch? Does it start with a niggling feeling that perhaps this might be an avenue that could bear fruit? Is that where it starts?
So I might
Please.
Look, it's a combination of things. I mean, there's a lot of serendipity in science as well, and I guess I'd argue that understanding fundamentals is really important. The discovery of Wi-Fi, who would have thought how it was going to change our worlds, was carried out as basic research. And so there are curiosity-driven questions which I think are very important, and one thing leads to another. One thing that struck me is how technology is really changing the way that we can do research at so many levels. For example, we're now interested in how looking at tumours as an ecosystem and normal tissue as an ecosystem. And there's technology that can be brought to bear where you can study the gene expression in every cell and see how that impacts on the adjacent cell. Is really opening a huge door for new questions and possibilities. So yes, there's a never-ending set of questions, but some of it's serendipitous. For example, even our work with BRCA1 to discover the cell type, it's not something that we specifically set out to do, to identify something that could be used to target BRCA1. So I think it requires a lot of people looking at in different perspectives, both from the laboratory, but also then, it absolutely needs people like breast cancer trials to drive a very specific question to the clinic. And then there are clinical outcomes that lead to new questions. So it's really a virtuous cycle.
I really like your point there about the role that technology plays to just lift all the boats in research. Kelly, I wonder if you might like to chip in on that. And while you're there, could you answer what I guess is my final question from this session, having heard everything about how everybody's breast cancer experience is unique and one person's treatment's going to be different to another person's treatment. But can I ask you, what you're most excited about in terms of research going into the future to improve treatments and preventions for people with genetic mutations?
Yes, I'll come to that in a minute, but I just do want to point out too that as researchers, we have ideas. I mean, I have ideas all day, every day. The hardest bit is actually designing a trial or a study where you can actually answer the question that you have. But I do want to make the point too that it shouldn't always just be about the ideas that we have as researchers, and that women with breast cancer or with a family history of cancer, consumers, as they're sometimes called, have a really important role to play in helping to direct us to what's important to real people out there, rather than us getting all excited about our own little specialty area. So I just want to highlight the importance of consumers helping to direct our research. And at Breast Cancer Trials, we have a consumer advisory panel who's really involved from the ground up when we first start talking about clinical trials, and they provide really useful advice to us as researchers about, where we've got it right and where we might have to tweak it a little bit. So just want to point that out. In terms of what I'm excited about going forward, I think the one thing that I would really like to see is that instead of those breast cancer incidence curves going up in this country and elsewhere as they are, I hope that in my lifetime I see the point where there's an inflection in those curves and breast cancer incidence starts to go down. And, I think one of the important things in terms of doing that is going to be about having women understand what their individual risk is. Are they at high risk or average risk? Do they need to be doing more than they're already doing? So I guess in a broad sense, that's what I'd like to see.
Anybody else want to jump in with anything that excites them, with the warning that you have about 90 seconds each?
Well, I might add the importance of consumers. I agree with that. Even in basic science now, we have a buddy program here at WeHi where consumers actually play a part in that, and so involvement at all levels is very important, because, as Kelly said, it's lots of people who are involved in research, and everybody can bring their own ideas to it.
For me, I think in terms of, where I would like the future to be is seeing an environment where, a society where the people who should have testing or should have these higher risk preventions are able to access that. We know at the moment that there are underserved populations, people of ethnically diverse backgrounds or other socioeconomic backgrounds who are less likely to have genetic testing. And then, as we've all been talking about, there are exciting things happening in terms of the care and treatment and prevention space. But if they're not being sort of recognized or not coming to our door, then it's just, the disadvantage just pile on. So I guess that's sort of what I'm hoping to see in the next sort of, decade or so, that we are all, the equity of access is there.
Well, thanks, Milita, and thanks to all of you. We are at the end of the session, but I just wanted to thank all of you individually, Geoff, Karen, Kelly and Milita, for the time that you've spent to deliver your advice and guidance and your generosity, particularly you, Karen, and sharing your own experiences. I'm super aware that on this big group listening into this session, we've got people who are in all different stages of this experience, whether they've had a cancer diagnosis or are worrying about themselves or family members. So before we go, I want to take the opportunity on behalf of the panel and of Breast Cancer Trials to wish you all very well on the course that you're on. I do want to remind you that this Q&A session has been recorded and will be available on the Breast Cancer Trials website tomorrow, so you can go back and watch it or show it to anybody else who you think might benefit from viewing it. The team will send everybody on this session a link that you'll be able to either watch or share. As you know, Breast Cancer Trials is committed to improving outcomes for every person diagnosed with breast cancer through clinical trials research. I encourage you to follow the link links that have been talked about this evening. And if you do consider making a donation or supporting breast cancer trials or participating in the trials, that's a fabulous thing to do for humanity. So you can do that via their website at www.breastcancertrials.org.au. Again, thank you very much to our panel, and thank you for your enthusiastic participation in this online session. I hope you have a wonderful evening. Thank you very much, and good night.